Good morning, class. Today we're going to do the venipuncture techniques and phlebotomy techniques, the syringe method. So the theory behind it: select the syringe and needle size compatible with the size and condition of the patient's vein and the amount of blood to be collected. To comply with OSHA regulations, you must select a needle locking syringe. Example, lower lock. To use for the draw and a syringe transfer device to transfer blood from the syringe to the ETS tubes. Syringes and syringe needles designed for blood collections are normally available in sterile pull-apart packages. The syringe plunger is typically already pulled back slightly to ensure that the plunger moves freely but still maintain syringe sterility. Move the plunger back and forth a few times and advance it to the end of the syringe before opening the sterile package. Open the needle packages in an aseptic manner and securely attach the needle to the syringe. A blood specimen collected in a syringe will have to be transferred to the ETS tubes. Small volume tubes are typically chosen because the amount of blood that can be collected in a syringe is limited. Partially open the package containing the transfer device to make removal easy when it comes time to use it. The reagents and the equipment that we'll be using. So we have 3 different sizes of needles here. This one is gauge 23, so what you will see is 23G. This one is gauge 22, so you will see 22G. And this one is gauge 21, you will see 21G. We have 3 different sizes, or the amount that we can draw in the syringe. We have the 3 ml, the 5 ml, and the 10 ml. We have the alcohol prep pads to cleanse the area. We have cotton balls. We have the adhesive bandage. And we have the ETS tubes. So we have 5 in particular that is commonly used. So we have the light blue, the lavender, the green, the gray, and the red. Then we have a box of gloves. The tourniquet, and this is where we're going to be disposing all this is a specific container. It's a 2-gallon infectious waste container where all the used needles and syringes and anything that is contaminated with blood will be placed into this container. So the procedure: wash hands thoroughly before beginning any phlebotomy procedure. Confirm the identity of the patient. This can be done by asking the patient's name or requesting to see the patient's identification card. In other words, class, what we need in order to check the person's identification will be a picture form of ID. Explain the procedure, including small risk of hematoma, slight pain, and some lightheadedness. Inquire whether patient has a history of fainting or dizziness with phlebotomy procedures so that ammonia inhalants can be obtained. Explain that loss of vacuum or collapsed vein might necessitate another draw. Position patients so that they are seated comfortably in a chair with arm extended on armrest or desk or table to form a straight line from the shoulder to the wrist. Arm and elbow should be firmly supported and not bent at the elbow. On a table or desk assembly, assemble all necessary equipment: cotton balls, tubes, needle, alcohol swab, tourniquet, gloves, and plasters. Wearing latex gloves is mandatory. Wear additional protective equipment if contamination is expected. Check both arms to select the larger and fuller veins. Palpate and trace the path of the veins several times with your index finger. Tap the vein at the side of the drawer with your index finger and second finger. This will cause the vein to dilate. The following factors should be considered in site selection. Extensive scarring. Healed burn areas should be avoided. Hematoma. Specimens collected from an area of hematoma may yield erroneous test results. If another vein is not available, the specimen should be collected distal to the hematoma. Specimen collection. Ask patient to open and close his or her fist so veins will become prominent. Vigorous hand pumping is not necessary to activate blood flow and should be avoided. Clean the venipuncture site with the alcohol swab in a circular motion from the center of the area to the outside. Allow the area to air dry to prevent hemolysis and burning sensation to the patient. Insert the needle into the vein, bevel up. There is confirmation of success when a small amount of blood appears in the back of the needle. This is often referred to as a flash. The plunger is then pulled backwards and blood fills the syringe. If the syringe plunger is pulled back too quickly, red blood cells may be broken, causing hemolysis by turbulence or physical forces as they are forced through the needle. Remove needle. Place cotton ball or a 2x2 square over the site. Apply pressure for 2 to 5 minutes. Place a band-aid over puncture site in case of any further bleeding. The blood is usually transferred quickly to vacutainer tubes before clotting sets in, following the correct order of draw. Wash hands thoroughly after phlebotomy. Class, we're going to do the syringe needle procedure from our phlebotomy book. It starts with page 265. So step 1 is to review and accession test requests. Second, approach, identify, and prepare the patient. 3, verify diet restriction and latex sensitivity. 4, sanitize hands. 5, position, apply tourniquet and ask patient to make a fist. 6, select vein, release tourniquet, ask patient to open fist. And 7, clean and air dry site. 8, prepare equipment and put on your gloves. 9, reapply tourniquet, uncap and inspect needle. 10, ask patient to make a fist, anchor vein and insert needle. 11, establish blood flow, release tourniquet, ask patient to open fist. 12, fill syringe. 13, place gauze, withdraw needle, activate safety device, apply pressure. 14, discard needle, fill tubes, discard syringe and transfer device. Label tubes. 15. 16, observe special handling instructions. 17, check patient's arm and apply bandage. 18, dispose of used and contaminated materials. And 19, thank patient, remove gloves and sanitize hands. And 20, transport specimen to the lab. So class, I'm going to show you how to assemble the syringe and needle together. So there's as said earlier, we pull it apart, and this is the actual needle. This is a 10 milliliter needle, syringe, and this is the needle. This is the 21G or 21 gauge needle. So, pull it apart. Pull, and you push on the plunger. Placed together, ready for use.
Really good tourniquet.
Class, when we do the syringe needle method, we need to know the order of draw when it pertains to the color tubes. So for the syringe method, it's light blue, lavender, green, gray, and red. So class, I want to talk about troubleshooting guides. If an incomplete collection or no blood is obtained, change the position of the needle. Move it forward. It may not be in the lumen, or move it backward. It may have penetrated too far. Adjust the angle. The bevel may be against the vein wall. Loosen the tourniquet. It may be obstructing blood flow. Try another tube. There may be no vacuum in the one being used. Re-anchor the vein. Veins sometimes roll away from the point of the needle and puncture site. So, troubleshooting guide number 2. If blood stops flowing into the tube, the vein may have collapsed. Resecure the tourniquet to ensure venous filling. If this is not successful, remove the needle, take care of the puncture site, and redraw. The needle may have pulled out of the vein when switching tubes. Hold equipment firmly and place fingers against patient's arm, using the flange for leverage when withdrawing and inserting tubes. Troubleshooting guide number 3, problems other than an incomplete collection. A hematoma forms under the skin adjacent to the puncture site. Release the tourniquet immediately and withdraw the needle. Apply firm pressure. Hematoma formation is a problem in older patients. The blood is bright red, arterial, rather than venous. Apply firm pressure for more than 5 minutes.